I'm Dr. Samir Muchala, heading the medical affairs for the Zydus Life Sciences Limited. It gives us immense pleasure to invite you today to this live webinar, BemTalk, on a newer concept known as Bempedoic acid. We all know the Interheart study suggested dyslipidemia is the single most cardiovascular risk factor. Statins form the cornerstone for dyslipidemia management. Unfortunately, new guidelines have more stringent levels or targets for LDL, and we are unable to achieve these targets despite maximal tolerated dose of statin. Also, especially in this subcontinent, a proportion of patients are statin intolerant. So we have a new concept today, bempedoic acid with a novel mechanism of action. And we have none other than Dr. Johann Christopher with us today to enlighten us. Although Dr. Johann requires no introduction, it is my moral responsibility to introduce Dr. Johann Christopher. Dr. Johann Christopher is Director of Cardiac Imaging at the CARE Hospital, Hyderabad. He's undergone a cardiac imaging fellowship from the reputed Harvard Medical School. He has numerous national and international publications in the field of cardiac imaging to his credit. He has given multiple orations on cardiac imaging at the local CSI and the national CSI forums. He has been a principal investigator for various international trials, just to name a few: MEDIC, ICARIS, CONSERVE, Ischemia, and SELECT. He's also in charge of the Big Picture Registry and executive member of Asian Society of Cardiac Imaging. A warm welcome to Dr. Johann Christopher. I request Dr. Johann to kindly take the academic proceedings forward. Thank you very much.
Thank you, Dr. Samir, for the kind introduction. Thank you, Zydus, for giving us this opportunity. These are interesting times for all of us, and having something new is always good. All of us like to have new things. And I think in the context of newness, I think it is important that we are able to connect and try to defeat what I call a great enemy, which is dyslipidemia. I just want to check with the tech team if my slides are moving and my audio is all right before I start.
Yeah, everything is fine, Dr. Johann.
Okay, right.
You is fine and the slide is visible.
Okay. So good evening, ladies and gentlemen. Again, thank you once again for spending your evening. We're going to be talking about an interesting molecule, and that molecule is called bempedoic acid. And today's theme by Zydus is unlocking concept and unleashing efficacy. Now, what are we standing in terms of coronary artery disease? Now, if you look at the Interheart study, which was a large study by Salim Youssef, almost 15,000 odd patients. And when they looked at the population attributable risk, and when you look at all risks, is 90. And if you see, the second highest is dyslipidemia at 50. There is no competitor anywhere in the horizon except for smokers. That is a distant second. So if you look at all the risks that you see, whether it is diabetes, obesity, abdominal obesity, alcohol, lack of exercise, sedentary lifestyle, there are a number of them. All of them were important and had a population attributable risk, but all of them came a very distant second to dyslipidemia. And that is the importance of dyslipidemia in the genesis of cardiovascular disease. Now, historically, if you look at the primary prevention trials, the trials which gave statins their place in modern dyslipidemia history today, their rightful place, I must say, started with the story with AFCAPS and TEXCAPS trial with around 6,000 odd patients with lovastatin. And then rapidly over the next 20 years, culminating in Jupiter, where we had the superstatin or the rosuvastatin, with about, I would say, 50 to 60,000 patient worth data, and clearly showed that when you started these drugs in the right patients, you got a 30 to 40% reduction in MACE. And these are patients who had not had a ASCVD to start with. When you move to the secondary prevention data, the FOREST trial from the Scandinavian countries using simvastatin, and then culminating in the ideal trial using a very high dose of atorvastatin of 80 milligrams, again showed in patients with uh, already prior events, mostly myocardial infarctions, a very resounding reduction in LDL to the range of between 25 to 50%, and also a corresponding significant benefit of anywhere between 20 to 30% reduction in mortality and re-MI. So statins in the history of dyslipidemia have proven their place in the primary and the secondary space. They have proven their role in LDL reduction, robust numbers, and also shown the clinical benefits of MACE reduction by using them. So we have no doubt in this meeting that statins are the priority, statins are the initiating drugs, statins are the first line therapy. But two concerns we would like to share with you, that in patients who are on statins, are they reaching goals as per the guidelines? And we'll talk about that a little later. And when we have come to the maximum dose of statin, which is generally rosuvastatin 40 and atorva 80, are we reaching those targets? Now, let us see what happens to our concern about reaching the LDL goals as per guidelines. Now, we do know from data that around a 38 milligram reduction of LDL is translating to around 24 to 25% reduction in MACE. Now, if you look at all the drugs that we have in the market today, starting with the fibrates and STMI at the lower end of the spectrum, moving on to statins somewhere right in the 50th percentile, and then of course the super drugs that we have today, the PCSK9 inhibitors, we know that there is a great spread between anywhere between about a 10% reduction up to almost 50% reduction. And statins are exactly somewhere in between at 25 to 30% in terms of the relative risk reduction for major vascular events. Now, this has prompted us to look at our KYC of our patients very closely and see their risk category, divide them into risk category of low risk, moderate risk, high risk, and very high risk. And by doing the KYC of our patients and getting into those risks, we have also come up with some interesting numbers, and these are European numbers, of 115 up to moderate risk and less than 100 for high risk. And the very high risk patients, especially patients who have recurrent vascular events and established ACVD at less than 70. And this is 2016. When we move to 2019, things have got a little more competitive. And it's now 115, 170, and the highest risk is demanding 55. Now, what is our position in terms of the lipid lowering with the drugs that we have? Now, this was looked at by a very large study called the Da Vinci study in the European Union, with almost 18 countries being involved and 6,000 odd patients. The primary and secondary prevention group were about 50% each. Now, if you look at all comers, you will see that the patients who used the high dose, high intensity statin, which are defined as 40 milligrams of rosuvastatin and 80 milligrams of atorvastatin, are a third, around 30%. We also want to bring your attention that the patients in the European Union using the PCSK9s, evolocumab especially, and inclisiran, were hardly 1%. And this is European Union data, not Indian data. 1.2% of the population uses PCSK9. I can't even imagine what that percentage would be in India. But so long, in terms of the reduction or the proportion of patients achieving their respective goals is only a third. So while a third of patients use high dose statins, again, only a third are achieving their goals. Now, what happens if you look at the very high risk patients where we're talking about a goal of 55? Again, a third of patients of very high risk use high dose statin, and only 1% is using PCSK9, showing you that although it is a great drug, a powerful drug, it's simply out of the reach for the many millions. But what is very abysmal is that when you look at the population reaching goals, and these are very high risk patients, and you know how important it is for them to reach the goals, they're looking at a very, very piddly 18%, very poor percentage of patients achieving goals. And this is European Union data from the Da Vinci study. And if you extrapolate this data to India, I really think that we are nowhere in the horizon in terms of the goal achievement. Now, the Korean data also came up, and they looked at about 5,000 odd patients. And because it's a homogeneous small country, 95% of those patients were on moderate to high risk statins. And if you look at how many achieved the LDL targets, which was generally less than 70 for those patients, it's only 22%. And in those patients who achieved LDL, they got a very good 37% MACE, showing us that LDL achievement is translating into a good decrease in MACE. But the people achieving the LDL is extremely low. We are very clear that dyslipidemia is a very important part and parcel of cardiovascular disease, a contributor of cardiovascular disease. We also know that by decreasing the dyslipidemia, you're getting a clinical benefit, as we have shown both in the Korean data and the European data. But what we are also trying to show is that the people reaching those targets are very small, 22% in the Korean data and only 18% in the European data. In India, I'm sure the numbers are low. Now, when you come to a good LDL defined as less than 70 or a more than 50% reduction, or a more than 70 and more than 50% reduction, the MACE is quite high. That means the MACE doubles if you're not able to reach the less than 70 mark, even if you're able to cut it down by 50%. So reaching targets is very, very important. And this is the Korean data. Now, when you've come up to the maximum tolerated dose of statin, and still you're not able to reach targets, what do you do? So here is where we're looking at what you can do with a traditional dose of statin. Now, moderate intensity statin, which is 20 of rosuvastatin and 40 of atorva, gives you a 30% reduction and approximately a 20% reduction in MACE. Highest dose statin gives you up to 50%, which is slightly more with rosuvastatin, maybe a little less with atorva. When you add on estimate, you get a 15% benefit to that, which is 65%. Using a PCSK9, which is generally once in 2 weeks, and inclisiran, I believe it is once in 6 months, you get a 60% benefit in terms of reduction, which is better than high intensity statin and estimate. But if you add a high intensity statin to PCSK9, then it is only 75%. And if you can add all three, it's 85%, which are very, very good numbers. So these are the numbers that are important. But what I would like to say is that if you look at the PCSK9 reduction of 60, you can get to that number fairly easily if we can get a statin, estimate, and the new kid on the block, bempedoic acid, which is far, far cheaper and easier to get there. Now, what is the wonder drug or new kid in the block that we're going to be talking about? The new kid is bempedoic acid. It's a new drug. It's relatively older. It's 2 years old, in fact, and it's an ATP citrate lyase inhibitor. It's a first-in-class lipid-lowering drug, approved in 2020 in the American and European markets. Also has FDA approval, and it has two major indications. One is to get the LDL down when you're already reached the maximum tolerated statin dose. And number two, in patients who have established ACVD or a familiar hypercholesterolemia or a mixed dyslipidemia to get the LDL down. The second big group is patients for some reason cannot tolerate a statin. Atorva to rosuvastatin to pravastatin, etc. You're still getting a significant statin intolerance. Neither by changing the statin or by decreasing the dose, you're able to get away. And those patients, again, bempedoic acid comes to the rescue. The dose is fixed. It's 180 milligram. It's a single dose once daily and doesn't worry about food. Now, if you look at the pathway of cholesterol synthesis, and this is familiar territory to us, the HMG-CoA inhibitor, and this is inhibited by statins, which is a rate-limiting pathway for cholesterol synthesis. You will see that as the cholesterol gets lower, there's an upregulation of the LDL receptors. And what this does is that it captures all the floating LDLs in the blood and thereby decreases the LDL levels. Now, just upstream to the HMG-CoA receptors, the ACL is inhibited by bempedoic-CoA, which incidentally becomes a prodrug after activation by the ASCVL1. Now, when you look at the skeletal muscle, again, there is a role of statin, and that also is the reason why the statin causes the myopathy. And this is an area where bempedoic acid does not act. And therefore, the whole muscle issue is completely obviated with bempedoic acid. But another problem of bempedoic acid, and I believe the only problem, is that it inhibits the OAT2 enzyme in the kidneys and therefore causes the increase in the uric acid and a mild increase in creatinine. So hyperuricemia is the bane of this product. Now, the half-life is almost 24 hours. 70% is out through the kidney and about 8 to 10% is through the fecal route. Now, there is no concerns in a patient with a chronic kidney disease, except if the GFR is less than 15%. No problem in mild to moderate hepatic impairment, except in severe hepatic impairment. Uric acid is mandatory to check in all patients. In a patient who's had a history of gout, you need to be very careful. And this group is what I'm really concerned about. Somebody above 60 on steroids or fluoroquinolones with CKD and has a history of tendon rupture. This is a group at this point of time in the drug's natural history, we don't want you to use it. 60-year-old CKD patient on steroids, fluoroquinolone, and a history of Achilles pain, Achilles tendon pain, please don't give it. Any patient who's on simvastatin more than 20 or pravastatin more than 40, do not give. And pregnancy and breastfeeding have not been studied, so please don't give the drug. So a patient who is elderly, above 60, with CKD, on steroids or fluoroquinolone, and a history of a prior tendon rupture, which is not a common problem, but it is there to ask as a history, do not give this drug. And if you avoid giving this drug, you're going to have years of good and comfortable, safe use with the drug. Now, the data behind bempedoic acid has been quite robust, and it goes with a very nice eponym of clear. Now, the data with statin is called the Clear Harmony and Clear Wisdom. And both these trials together were about 3,000 odd patients, with a large number of these patients having atherosclerotic heart disease, hypertensive and diabetic, and over a 52-week program. Now, the Clear Serenity and the Clear Tranquility are drugs trials which have been done in patients with little or no um, statin therapy on board, simply because they were very intolerant. The Clear Serenity looked at patients with ACVD, and the Tranquility looked at patients with only risk factors like hypertensive and diabetic. Now, the Harmony and the Wisdom trial together over a 1-year period, all of these patients had statin, clearly showed that on statin use patients, the effect of bempedoic acid was a very robust decrease in LDL cholesterol. And this happened about 4 weeks into the therapy. Very early, we were getting that benefit. And it was statistically significant of about around 12% reduction, and a 10% reduction in non-HDL cholesterol, again, very early movement of the line below, a 10% reduction in total cholesterol, and 6% reduction in apolipoprotein B, which is very specific for Indians. So we're getting some good numbers on these patients over and above statin therapy of between 10 to 12% reduction. And LDL goes up to almost 18% in the early days. In the Clear Wisdom trial, again, we got a 17% reduction of LDL over a 1-year period. And there was some added benefits or collateral benefits of non-HDL, which we know is important in India, of around 11%, total cholesterol of around 10%, and ApoB also 10%. So roughly 10% reductions in the non-HDL, total cholesterol, and ApoB. Now, when we move to the trial which looked at statin intolerant patients, here the bempedoic acid was added to estimate. And again, a shorter trial of about a month, about 3 to 4 months. And small number of them still had small doses of statin, and they looked at safety. And this is what they got. When you had patients on bempedoic acid and estimate without a statin or on very low doses of statin, you see the bempedoic arm had a 28% benefit over the placebo in terms of LDL reduction, and a fairly robust reduction of around 14 to 15% reduction in the non-HDL space, total cholesterol, and ApoB. And remember, this reduction that we're looking at is without an underlying statin. So without statin, about 15% in the rest, and about 28% with LDL. And here you're getting an almost an 18% benefit over and above statins. Now, the phase 3 trial looked at estimate acid alone, bempedoic acid alone, and the addition of both in a fixed drug combination. And we found that the LDL reduction at week 12 was a whopping 36% if you were able to have both the drugs on board over a 12-week period or a 3-month period. And these patients were high-risk patients. They were patients with familial heterozygous hyperlipidemia. These patients had an underlying atherosclerotic cardiovascular disease. These patients had a high LDL of more than 100. This group already had statin, the maximum tolerated statin therapy. And on top of that, we're getting this 36% benefit. And the non-HDL reduction and the ApoB reduction was also quite impressive at around 31 and 25% respectively. Now, what we don't have with this drug is a CVOT data, which statins are famous for, but not to worry. By the beginning of next year, we will have 14,000 patients phase 3 clinical trial with bempedoic acid and uh, MACE reduction, both in the primary and the secondary space. And again, we are looking at an event-driven trial of almost 1,620. So that will be a very significant trial when it does come out. And that will tell us about the CVOT reduction with bempedoic acid. What is also important is based on the clear data that we have found, the ADA in 2022 mentioned bempedoic acid as a very important drug in LDL reduction. Now, the other area with bempedoic acid works, as I said, it works on the acetyl-CoA cycle. It works on the malonyl-CoA cycle. Thereby, you're going to have some triglyceride reduction of around 10%. But also, it specifically works on the AMPK enzyme, which is generally present in macrophages. And it causes a reduction in the inflammatory cytokines like the IL-1 beta, 6, 8, and the TNF alpha, very potent inflammatory markers. And what that does by their reduction is a decrease in hsCRP, which we know is a very good surrogate endpoint for coronary inflammation. And these are the impressive numbers that we get from the CLEAR series, the CLEAR Harmony, Wisdom, Tranquility, and Serenity. Whether you are with statin, you get a 20% odd reduction of hsCRP, and even without the statin, you're getting almost a 25 to 30% reduction in CRP, showing us that this product not only decreases LDL, but also decreases hsCRP, which is a very important component of MACE events, and which the statins also do the same way. So looking at the problems of bempedoic acid, we did mention the hyperuricemia, we did mention gout, mild increase in ALT, AST, some amount of anemia, tendon rupture, we said was a very important problem, especially if the patient has a prior tendon problem. And what is important is that the chance of getting diabetes is again quite low, or even less than placebo. And this is an area which has been plaguing us and causing a lot of consternation at meetings about the incidence of new onset diabetes with statin usage, which is now crossing around 10 to 15%. And here you are getting a 0% increase in diabetes. So I think that's very, very important in terms of the niche role bempedoic acid is going to play. Number one, showing us that it is a safe molecule, but it does not increase the diabetes, which is very important. So to summarize, ladies and gentlemen, uncontrolled LDL cholesterol is a major risk factor for cardiovascular disease. We know the role of statins from the VOSCAPS and PEGSAP study in terms of primary prevention, and the FOREST data in secondary prevention, to the big trials of today, the Jupiter trial and the other trials are using atorvastatin, including the important trials. So statin is therefore the number one choice in terms of dyslipidemia management, should be the first drug. But we do have a residual risk in patients even after the high intensity statin. Almost 70% will have uncontrolled LDL cholesterol. And the risk when you have that uncontrolled LDL cholesterol is quite huge, anywhere between 60 to 70%. So in this unmet area, and this unmet need, and this residual risk, bempedoic acid is the first drug that has a unique mechanism of action. It acts upstream of the statin. You have a good reduction of 18% when you're adding it on top of the statin, and you're getting another about 15 to 17% reduction when you're adding it with estomide without the underlying statin. Up to GFR 30 can be given easily, no problems. We don't have data with less than CKD, less than 15%. We do know that a person who's elderly more than 60 with CKD on fluoroquinolones as well as steroids and a history of tendon rupture, we don't want to give the drug. We want to avoid it in these early days, and then later as it enters the mainstream, we can always use the drug. Please look at the uric acid levels before you start. please look at uric acid about a month after you start so that we make sure that we are not getting into hyperuricemia. We also want to take that history of gout, painful arthritis, for example, before we start the drug. I think that will really complete a very good safety checklist when we use the drug. Thank you very much once again for this wonderful opportunity and wonderful years for all of you to use this really good drug. Thank you. Over to you, Samir.
Yeah, thanks, Dr. Christopher. I think that was a real lucid presentation. I'm just going through the feedback received from the delegates, and there's a very good feedback with respect to the clarity with which you have orated the new molecule in a very lucid way. We have few questions posted by the delegates, so I'll just address one by one. The first question is from Dr. Raghuramullu from Hyderabad. His question is how long bempedoic acid needs to be continued after controlling the LDL below 75 milligram per deciliter.
Yeah, so LDL reduction, as we reiterated, is very important. We need to get to those levels as specified by the KYC of the patient. Know your patient. You need to know whether your patient is low risk. You need to know your patient is very high risk or high risk. So once you know your patient well, you know the LDL target. We need to get to that target. We need to get to that target quickly because any delay will expose this patient to harmful effects. As with the statins, and of course, these are early days, we want to maintain the therapy which got him there. We want to maintain that therapy which got him to that 70 or 55, depending on which target you're looking at. We would believe it will take you anywhere between 1 to 3 months to get there. But once you are there, I would believe seeing the relative safety of this drug, it's worth keeping the patient on the drug unless you have another issue of hyperuricemia or you have some cost issues coming up, then one could possibly take the drug out. But I would believe that keeping the drug which got him to that number and maintaining him at that number, it's not only reaching, but you got to maintain, you got to keep him at that level is very important. So as long as you're able to do that, it's obviously a physician's choice when to withdraw. And there'll be so many factors, I'm sure, for each one of us. Maybe cost, it may be side effects, it may be pill burden. So all those things as a physician, you're entitled to take. But we want you to reach the goal and we want you to keep at that goal. That's the message to me.
Dr. Patel from Ahmedabad has a question. According to you, how low is very low with respect to LDL levels?
Yeah, I don't want to inject our personal preferences. We saw the European data, and European data is a very robust data. It's not too extreme like the American data. I think they have done a lot of work. The Da Vinci trial also looked at the real world experience. I think their 2016 guidelines were good. The 2019 are a little ambitious. We know we have some Indian guidelines by the Lipid Society. And there we have a special mention, I believe, for the non-HDL, which seems to be more applicable to the Indian population. But just if we were to follow the European 2016 guidelines, I still believe we have a lot of work to do. So I'm not really worried about how low I want to go. I want to follow any guideline, any society, that's okay with me. Even following the 2016 European guidelines, I find it very challenging. So I think we should look at what we can really do, what we can really, target. It has to be a feasible target in our population. We have a lot of challenges, as you know. So I think it's important to do a KYC of our patient, know which category stands, and then appropriately target the Indian as per that, not getting everybody down to 25 or 30 or whatever. Saying that, I will just give you a small illustration of a community in Peru, which lives in a very small, landlocked, isolated part of the Andes Mountains. And when these American researchers somehow reached them, they found that the average level, average age of those people were around 90 years, average of that small community. And when they checked their lipids, they found that the average lipids were around 30. So 25, 30, and we've seen those numbers happening with the PCSK9 inhibitors, I believe are very reasonable targets. You're not going to cause extra cancer or uh, things like that. But these are not targets I would put on a society. These are not targets that you can just slap onto a ethnic population like India, which is so varied. I think we just follow one of the guidelines. The European, American, Indian guidelines are available. As a physician, it's your call, and we go by that.
There is a related comment rather than a question by Dr. Kumar from Delhi, that the recent 2019 European guidelines suggest a level of around less than 55 in the very high risk category, and LAI also suggests less than 50. So the comment is that usually European and Indian guidelines usually go hand in hand. So the point what is trying to make is the Da Vinci study would also apply to the Indian population in view of this. That's the comment which is there in the comment box from Dr. Kumar from
Yeah,
Delhi.
while I agree the LAI is very close to the European, I don't think we're anywhere near Da Vinci, what Da Vinci has shown. If you look at 30% of patients receiving high dose statins, I don't have all the numbers obviously, but I think our numbers are more like less than 10% on high dose statin. I think that's the number. And if you feel 30% of patients are receiving, are getting to goal in the European Union, I would say we're just one third of it. I may be a little pessimistic, correct me, but whatever data that we have, and that's very limited, very focal data, nothing like this large, big Da Vinci study that we've ever done. I am quite pessimistic. So pardon me, but I'm sure everybody has their own opinions.
Sure. So Mehta from Rajkot has a question. In your clinical practice, how frequently do you come across patients with statin intolerance?
Yeah, my numbers in the last 20 years of experience are somewhere in the 5% or 5 to 8%. That's the group I have. We have managed to surmount those with changing the statin, decreasing the dose, using rarely used statins like pravastatin and things like that. But those numbers are still there. So there's a group of patients who just can't use any statin at any dose. They're also vulnerable patients. So I think we got a shot in the arm with bempedoic acid. With estimab, we were able to get less than 10% reduction because estimab, works only by decreasing the cholesterol intake. It works at the cholesterol absorption level. It doesn't do anything after that. And we know that 85% of your LDL is manufactured within and is not absorbed. So just by its nature of function or nature of mechanism of action, estimab is severely limited in what it can do. So we really never had a good, what I would say, second, batsman to speak till bempedoic acid came. Bempedoic acid, I believe, has got some really good mechanistic actions. And if you look at the data for the last 2 years, the clear data, I think we are standing on a very strong wicket. And my take, and I was just telling that to Samir just before, is that when you add an estimab, when you add a bempedoic acid to a high dose statin defined as either 40 of rosuvastatin or 80, you are touching 65% reduction of LDL, which is
Yes.
very, very good and reasonable when you're doing the same thing by using the evolocumab, which is a PCSK9, which even in the European Union is less than 1% of the population. And here, even if I say 0.3%, I may be still wrong. So we are getting to levels of evolocumab with the 3 drugs. The best part is these 3 drugs are friends. They work well together. They have synergistic mechanism of action. And I believe the day will soon come, and we already have an FDC with estimab and bempedoic acid. The day will come when we're going to have some kind of an FDC with the statin, estimab, and bempedoic acid for these difficult to reach out patients. But
Sure.
these are early days, so I think.
So I'll just take a related question by Dr. Shetty from Chennai. So his question is, can we give bempedoic acid along with ezetimibe without initiating statins?
Yes, and it was shown in both the clear studies where the patients were clearly intolerant to statin, they did use estomib and bempedoic acid. They used it well. There is data coming out of an FDC also with both the drugs. Forget about adding both together. And the good, robust reduction of anywhere between 15 to 19% of LDL without a statin, I think it's quite reasonable. And also the very fact you can actually complex them together, and the data has also come out with that, is augurs well for that combination. So safety is guaranteed, and you're getting a robust reduction of 15 to 18% without a statin on board. I think that's good.
So another question is, as bempedoic acid is used as an add-on to statins, and ezetimibe is also a non-statin therapy. Now there is uh, beneficial effects, good robust effect of bempedoic acid on HSCRP. So would it form as an edge over bempedoic acid over ezetimibe? Would the use of bempedoic acid over ezetimibe be an edge in terms of HSCRP reduction as an add-on to statin?
Yeah, so I'm not looking at competing molecules. If you've seen the data on dyslipidemia, how it contributes to cardiovascular disease, and if you look at the unmet need, if you look at the residual risk, we are far away from a single product dominating the market. In this scenario, I believe more is merrier. Any added help will go a long way in getting our society's risk levels down. So I don't see any conflict between estimate, which is a purely cholesterol inhibitor, absorption inhibitor, and here it's an inhibitor of the ACL enzyme, which is part of the cholesterol biosynthetic pathway. Absolutely, there is no interference. They work in a completely different mechanism of action. They're very synergistic, and they're very safe to use together. So to me, there is no conflict at all. In fact, if there is a patient who comes to me who's statin intolerant, I've not had that patient for the last 1 month since bempedoic acid has been done. I'll happily add estimate to it and go with whatever LDL I can get down. So to me, there is no competition in this space. More is merrier. We have come down to 65% with these three drugs. Another new molecule also is welcome. So like heart failure, I think we need to have all players come in very early, be added early, and don't wait for escalating doses. I think the same principle is in lipidology. You need to get all those players in. We have data about safety. We have data about synergistic action. And we also have data that we're clearly missing our desired numbers by a big margin. So no competition.
Dr. Mallu from Hyderabad, again, he has a comment. Increasing uric acid levels by using bempedoic acid may require stopping of the drug, as this is an independent risk factor for coronary artery disease. So it's just a comment from his end. So I thought
uric acid hyperuricemia, we need to watch for it. We need to check on it. But I don't see really any issues about it because we have some very good drugs in the market. Um, the fibrate drugs are available in the market, which are very good in reducing the uric acid compared to what we had previously, colchicine, etc. So we have excellent drugs available in the market to decrease the uric acid. We are using them very commonly. We do understand uric acid is an important risk factor, and we are trying to aggressively come down. I don't think this is going to be a major issue with bempedoic because we have these drugs. They are a single-use drug, once-day drug at 40 milligrams a day. Give it for a month and the uric acid comes down quite well. So I don't see this as a challenge. But yes, you need to check the uric acid at the start and end about 4 weeks and be careful. I don't see necessitate a stoppage of bempedoic at this point, but these are early days. We'll keep watching this space.
So another related question from Dr. Mahi from Pune. Uh, how would you monitor patients with who are on bempedoic, who are started on bempedoic acid, but they still have high uric acid level? That is scenario one. Or second, they have normal uric acid levels and started on bempedoic acid. How frequently would we monitor the uric acid levels?
Somebody with a high uric acid to start with, which I'm going to do anyway, that's part of my checklist for bempedoic acid. I don't start the drug. I start him on a drug. As I said, the fabric group of drugs, 40 milligrams once a day, wait for a month, check the uric acid down, I'm going to start. I may continue the hypouricemic acid, the uric acid reducing drugs along the way for at least another month to make sure that there's not rising again. I want to make sure there's no history of acute gout in the past. That's for sure. The general recommendation, and these are early recommendations, is that you do it at 0 before you start. Repeat it at 1 month. If the uric acid is stable, I don't think there's any requirement to repeat it again. But as we start using the drug, different kind of patients, I'm sure we will all have a flavor of how to do a surveillance of uric acid. But as of now, 0 and 1 month, I think should be fine.
Okay. Dr. Roy from Guwahati has a question. Would we consider bempedoic acid to be an economical or a poor man's PCSK9?
I would believe so. You've seen the European data, 1%. As I said, I can't even imagine India, even 0.2% would be a stretch of my imagination. I think cost, when you're looking at societal reduction, I'm not talking about individual patients. I'm sure there are a number of us who can afford a PCSK9 inhibitor, but when I'm looking at a society as a whole, as a country, I don't think we are in a position where we can implement PCSK9 in our population. Just my humble opinion. I believe the trio of statin high dose, bempedoic acid single dose, and estimate 10 milligrams is a great way to achieve our goals as a country in a very economical fashion. I don't see any controversy in that. Yeah, if you want to call it a poor man's thing, go ahead. I would also do this.
One again related question from Dr. Roy. Can bempedoic acid be given with PCSK9 and what would be the expected results?
I don't think that has been studied as of now. PCSK9 with statin has been studied, and there is data for almost, I would say, up to 80% reduction. We don't have the data as yet, so I can't comment. But I'm sure you're getting 60% reduction with the PCSK9, add another 18%, which is what the data is showing. So a very robust 80% reduction would be a fairly good number. So if you do have that patient who can't take a statin and is at the very highest risk, recurrent vascular disease over a 6 months period, you can afford PCSK9, either the once in 2 weeks or the once in 6 months therapy. I think there's no harm in adding bempedoic acid. It's a very safe molecule. I call it a great team player along with estimate. The beauty of these drugs is that lipid reduction is good, or I would say, above average. But what is very important, it does it in a very safe manner. It does it with decreasing the HSCRP, which is important for us, and it does it with little or no side effects. So I think that's great. That's very, very great news to augur for this molecule.
Dr. Manjrekar from Pune has a question. How exciting is the theoretical fact that bempedoic acid does not get activated in the muscle from the myopathy perspective?
Yeah, myopathy has been the bane for us with statin. It's been really pulling us down in terms of statin utilization. So I am very excited, but we should remember that what works in the lab and what works as a mechanistic thing does not play out in clinical trial. So we have had these wonderful molecules, HDL reducing molecules, which have shown such good things in the lab, getting the HDLs up and things like that, or getting the triglycerides down, but they've never contributed to MACE reduction. So while I'm obviously excited by this mechanistic principle, these are too early days. We need to watch that space carefully. We need to watch those muscles. We need to see the CPK carefully, at least at a distance, before we make some big judgments. But as of now, I would say it is a relatively safe drug for the muscle issue.
So I think we have come end of the question. There are many questions, but they are repetitive. So before we close, can we have the final take-home messages from your end?
Yes, I think I would thank Dr. Samir for moderating this very exciting sort of meeting conclave on bempedoic acid. It's a great new player. I believe it's a player that has come at the right time, and the when the guidelines have become aggressive, when we realize that we have a huge scourge of heart disease or cardiovascular disease in our population, we realize that lipids are the number one enemy in the population. And we've been struggling with getting statins at the right dose in our population due to various myths and problems, muscle problems being one of the common ones. We've been struggling to find a partner to add in our armamentarium. Estimab has come, but it is a weak inhibitor. PCSK has come, but it is out of the reach for many millions Indians. So I think bempedoic acid has come at a very optimal time when we as a country are wanting to deal with this menace in a very sure-footed manner. I would almost think of it, I'm not political, but I would almost think of it as an anti-tank missile which the Ukrainians got in the face of the Russian tank invasion. So sorry for being political, but that is how important bempedoic acid, I believe, is for helping our population. That's the final message.
Thank you. Thank you, Dr. Johan. I think that was a great illustration of this new concept, a very lucid presentation. And I guess in addition to the positive comments that we have received, the way you have handled the questions, because since it is a new concept, there would be many queries in the minds of the practicing physicians, especially when it relates to LDL and cardiovascular disease. So, and you have really, in a very lucid way and a crisp way, addressed all the queries. So, my special thanks to you for making it today, sparing your precious time, and my thanks to all the delegates also for sparing their precious time for attending this BemTalk webinar. So thank you very much, and may we all wish each other a very safe 2022 ahead. Thank you.
Thank you very much, Samir, and thank you, everybody, and also the Zydus